having abnormal bleeding or postmenopausal bleeding and your doctor told you needed a hysteroscopy with D&C, and maybe you weren't sure exactly what that meant or what some of the steps were for that procedure, well, today we're going to talk about the hysteroscopy and D&C. If that sounds good to you, continue watching. Well, welcome back to my channel. I'm Dr. DuPont. I'm a board-certified gynecologic oncologist, and I'm passionate about educating women on how to live healthy and productive lives, and I believe that begins with great health. Now, I did this video last year, so I'm doing kind of an update for 2025, and this was my very first video that went viral, so thank you so much for those who watched it last year. I hope you enjoyed it, and I'm going to try to make it even better this year. Well, the hysteroscopy and D&C is one of the most common procedures that we do, and there's several different reasons why we do the hysteroscopy and D&C. Now, I do have a video on the endometrial biopsy and the office hysteroscopy with endometrial biopsy because this can be done in the office, but typically for some patients, it's not appropriate for them to have it done in the office, so we'll do it in the operating room. So some of the causes or some of the symptoms that cause us to do the office biopsy are a little bit different than what causes us to do the hysteroscopy and D&C in the OR. So in the OR, a lot of times we'll do it for cervical stenosis, and that's when the opening of the cervix is scarred and we can't get our instruments in the office. And so a lot of times what I'll do is I'll open that os or the opening of the uterus in the operating room by using a scalpel, and so it'll cause more bleeding and more pain. So that one I will do in the OR under anesthesia. Removal of submucosal fibroids. So some fibroids can be removed in the office. I don't typically do that, but some GYN doctors that do a lot of office-based surgery, they feel comfortable doing it. So usually the simple ones that are just in the cavity can be removed, but if they're going into the muscle or they're more complex, most of us will do those in the operating room and not in the office. Now, if you have a lot of polyps, most of the time we'll do those in the operating room. If you're high risk for bleeding, if you have a bleeding disorder, or if you're on blood thinners, I'll do those patients in the operating room and not in the office. If you're unable to tolerate the office procedure, let's say it was just too painful and you just said it's just too much, I can't do it, then for those patients we'll definitely put them asleep and do it in the operating room. Remaining tissue after a miscarriage is another common cause for a D&C in the operating room. Usually we'll do what's called a suction D&C. And then if an IUD is dislodged, now a lot of times we're able to remove an IUD, let's say it went into the muscle of the uterus or it kind of got crooked or we couldn't find the string so we couldn't get it out. A lot of times we can do an office hysteroscopy and get that out, but let's say we weren't able to see it or if it was embedded in the uterus. I had one patient that had hers, it was embedded in the uterus, someone else had put it in and it was really hard to get out, but usually in the OR under anesthesia, it's much easier. We can tug and pull a little bit stronger to be able to get a foreign object like an IUD out. And other reasons would be to evaluate causes of recurrent miscarriage. So typically if you have, a lot of miscarriages, the infertility doctor may do a D&C in the operating room to kind of see why you're having recurrent miscarriages. And also the other reason is, let's say you have a septum of the uterus where there's like a kind of a dividing wall that can be removed easily with a hysteroscope, and so we do that in the operating room. And then adhesions, if you have something called Asherman syndrome where you have a lot of scar tissue maybe from prior procedures of the uterus, that can also be treated, and those we do in the operating room. So there's a lot of things we do in the office, but there's some very particular cases where we need to do those under general anesthesia or in the operating room under anesthesia. So in terms of the hysteroscopy with D&C, the procedure is very straightforward. Typically once you're asleep and you're comfortable, we'll position your legs so that we can, get you comfortable and put our instruments in so that we can see. A lot of times we'll use a either weighted speculum or I like to use a sidearm speculum to be able to see the cervix, and then I'll do the hysteroscopy part. Hysteroscopy is just a camera with the little light source that allows us to see inside the cavity. Now, because the uterus is a potential space, so the walls are flush, they're not open, we will put fluid. So the fluid or CO2 will distend it so we can see inside, and then once we have that cavity distended, we're able to see if there's any uterine pathology inside or anything abnormal that may be causing your bleeding, or if we're removing the IUD, or if you've had miscarriages, whatever we need to do to treat your condition, we can see a lot better once that fluid medium has been used. There's many different types of fluid medium. We now have, hysteroscopic systems that measure how much fluid goes in and how much fluid comes out. And so that allows us to keep track of it so that we don't have too much fluid and you don't have overload. Some of the complications would be low sodium, and it could cause electrolyte abnormalities. And so we do try to make sure that we monitor how much fluid is going in and how much fluid is going out. I had a patient last year when I did this video that asked a question question about, do we get the fluid into the abdomen? Theoretically it's possible because the fallopian tubes are open, and you can, if you haven't had a tubal ligation, that fluid can go out. Someone else asked me last year, do we spread cancer if there's cancer? Now, theoretically, you probably could, because that fluid with the hysteroscope, if it pushes out through the fallopian tubes, this is in the abdomen, so it can spread that, but we don't feel that will cause your cancer to spread, and there's not enough data to see if patients have worse outcomes. A lot of times if that fluid does get into the abdomen, as far as studies have shown, it doesn't cause any significant problems, but I guess theoretically, some of that fluid, if there were cancer, could come out. If you've had a tubal ligation though, where your tube was removed or scarred, then that won't happen, because the tube is how the fluid would get to the peritoneal cavity. So it's a theoretical concern. It doesn't seem to affect prognosis of uterine cancer, but I did have someone last year ask me that question. So I did want to make sure I addressed it this year. So after the hysteroscopy, then typically we'll do a biopsy. So either a D&C, where we will do kind of a scraping. Most people know of a D&C because they've had someone in the family that had a miscarriage. So I tell patients the D for the D&C is dilate. So the first part is we'll dilate the cervix. And a lot of times with the hysteroscopy, we've already had to dilate a little bit. I've done a lot more hydrodissecting, where I'll just use the fluid to dissect or dilate just with the water or saline that I'm using, but sometimes we do have to dilate to get our instruments in for the D&C. And then once we do that, we're able to get, a scraping of the lining. Now keep in mind, even though we're doing a D&C, we're not getting all of the lining out. We're just really getting a representative portion of it. So, if you have a D&C and you're still having bleeding, like, sometimes I'll have patients that I'll do a hysteroscopy and I'm able to see a polyp and remove that polyp. Sometimes those polyps grow back, and I'll have patients, a year later or 6 months later, they're having bleeding again. If that polyp was benign, then a lot of times, I may repeat the D&C to see if they're having, if that polyp just grew back. Sometimes though, you can miss things. So, if I have someone I'm concerned about cancer and I've done several D&Cs and I'm not getting any diagnosis of anything abnormal, but they're still bleeding and it's not making sense, then a lot of times I'll say, we've done all of the normal things and you're still bleeding, there's something not right. So sometimes we do have to do a hysterectomy to remove the whole uterus, because that's the only way the pathologist can find anything that's maybe in the muscle or deeper to be able to diagnose the reason. So again, if you're having bleeding that's just not going away or not getting better despite having biopsies, then your doctor may want to, talk to you about additional testing or even a hysterectomy. I am more concerned about that because I'm a G1 oncologist, so I see patients with cancer, and so I don't want to miss a cancer. So that's something that, I have to tell patients, if the bleeding's not getting better, we've removed these polyps that are benign, I'm concerned there may be something else happening. So just keep in mind, if your symptoms aren't getting better, a lot of times we have to keep investigating until we solve the problem. But typically after the hysteroscopy, and a lot of our new hysteroscopes now will have ways that we can biopsy things, either remove fibroids or remove polyps. So a lot of times we'll do what's kind of like a visual D&C. We'll look and maybe remove like a biopsy or area, because we're able to see so nicely with some of the newer hysteroscope systems. But typically after the hysteroscope, we'll do a biopsy of some sort. So depending on the reason you're doing it, typically we'll get some type of pathology and we send that to the pathologist for evaluation. After the procedure's done, typically it's a short procedure. Most patients, go to recovery room after they've left the operating room, and the nurses will monitor your pain. They'll monitor your vital signs to make sure you're doing well. And a lot of times patients go home that same day. For my patients, I tell them, still have pelvic rest for actually up to 6 weeks. So I don't want them to go swimming or being in a hot tub or having intercourse. I want to make sure we reduce the risk of infection and allow the uterus time to heal. Women will have bleeding after the procedure. It's very common. And then I also tell women that are maybe still having their menstrual cycles that, your next cycle may be heavier than normal, or the timing may be off, because sometimes the stress of surgery will make your cycles a little bit irregular. But typically after the 1 or 2 cycles, your cycle goes back to its normal pattern. But some of the complications of the procedure, again, are pain, infection, bleeding, uterine perforation. Now what that means is that sometimes, because our instruments are metal and they're stiffer, we can actually poke a hole in the uterus. It's very, very uncommon, but it can happen. It's like less than 1%. Typically, if the instruments go through the top, where we have a perforation. The uterus is a muscle and it heals very nicely, but if it's lateral, then we do worry about internal bleeding because a lot of our blood supply to the uterus comes lateral. So sometimes we'll have to do a laparoscopic surgery where we look in the abdomen to make sure there's no internal bleeding. It doesn't happen very often, but it is one of the reported complications. And then also you can have scar tissue that forms. So anytime we do a procedure, you can get scar tissue. So some women make more scar tissue than others. So Asherman syndrome or scar tissue is just one of the risk factors to the surgery. It's not very common, but it does happen. Well, I hope that was helpful. And typically, you know, after your procedure, your doctor will see you back 1 to 2 weeks and go over the pathology report and then make a plan as to how to treat whatever symptom you had that required the hysteroscopy with D&C. I hope you found that video helpful, and I thank you for watching to the very, very end. I do have several videos on different surgical procedures and also causes of abnormal bleeding. So if that's of interest to you, please watch this video next, and I'll see you next time. Bye-bye.